Professor Ehrenfried Schindler was elected as the first professor of pediatric anesthesia in 2019 at the University of Bonn. Before that, he was head of department for pediatric anesthesia and later medical director at the Children's Hospital of St. August in Germany. His main interest is care for critical ill children, and his research focuses on anesthesia for children with congenital heart disease. Additionally, he has been one of the pioneers in introducing the concept of enhanced recovery after congenital heart surgery. So please, Dr. Schindler will talk about the use of vasopressors in the prevention or treatment of low cardiac output syndrome in children. Thank you.
Yeah, thank you very much for this very kind introductions. Ladies and gentlemen, it's an absolutely pleasure to be here tonight with this excellent organized webinar. And it's really a shame that we cannot meet personally, but yeah, we have to do the best out of it. Most of us who are not dealing with the complicated pediatric cardiac cases are just measuring a very few components of circulation, and that is the heart rate, the saturation, and the blood pressure. And we all know that the blood pressure is just a poor parameter to estimate cardiac output, but it's a very easy to estimate and parameter, and it's the one we all have available in our clinical routine. And so what is influencing the blood pressure in children during anesthesia? And we have a lot of parameters, and that is the ventilation. It's if we're doing regional anesthesia, temperature is a significant, can be a significant influence parameter for blood pressure. Think about cool down the patient and then vasoconstriction. Volume could be, but most of these parts, like the volume, the sepsis, the regional anesthetics, are influencing the blood pressure because they are creating a significant vasodilation. So, and if we are looking at blood pressure, this is the equation of the cardiac output. And the cardiac output itself, we all know that's the heart rate and the ejection, the ejection of the heart. And we can manipulate this with, for example, with inotropes or with volume. But the most significant parameter here is the systemic vascular resistance. And the systemic vascular resistance is very easy for us can be influenced very easily. And so if you look at the origin of blood pressure, where blood pressure is being set up, and that is the capillary region. So it makes sense to influence the blood pressure in the region where it should be influenced, and that is the precapillary sphincters. So if we decrease the precapillary sphincters, we increase the systemic vascular resistance. And on the other hand, with vasodilation, we can decrease the precapillary sphincters. So we should use drugs acting at this part of the circulation. And if thinking about vasoconstrictions, these are vasopressors. This is a very interesting example that it's not only physiologically parameter driven, the therapy, it can also be a question of culture. And here physicians were asked from the United States and from, I cannot say Europe because this is only Denmark, and it's a little bit unfair to compare Denmark with the whole United States. Okay, these are Vikings, but I mean, this should be an example that cultural differences can also occur in pharmacokinetic therapy. And if you ask about what is your favorite drug or what is the right drug, to influence the peripheral vascular resistance, or to increase the peripheral vascular resistance. The people in the US, they were using a bunch of variety of different drugs like norepinephrine, vasopressin, or dopamine, or dobutamine. So we have a bundle of drugs that were used, whereas in the European perspective, and I would say Denmark could be representative for the Europe, the norepinephrine was the most used vasopressor. Vasopressin does not have any impact in a clinical routine in the Europe. If you look at this study here, that was a multi-center study from, I would say, worldwide multi-center studies, whereas also the focus is more United States and the Europe, but also a lot of other countries were asked, what is your favorite strategy to have your, or what is your main dominant therapy in therapeuting low cardiac output? And the majority, and these are not anesthesiologists asked, these were intensivists, the majority of them were responding that their main drug is the milrinone and the adrenaline in the first line therapy of low cardiac output, whereas the second line, and that is interesting, the second line was noradrenaline or norepinephrine. So the other drugs also have a minor use in this questionnaire. Again, we're coming out of this questionnaire, and David Faraoni also pointed out that we have a lot of very good parameters besides blood pressure to decide if we have a low cardiac output or not. And most of these clinicians were using the lactate, the physical examination, and SVO2, as well as the echocardiography, as the main parameter to measuring or estimating cardiac output. If you're asking them, what is your favorite drug to prevent the low cardiac output? None of them were responding that they were using vasopressors. So the idea is in prevention of low cardiac output, most of them were just using the milrinone, so that is a vasodilator, or a so-called inodilators like the milrinone or the dobutamine. That was a questionnaire we published coming out from Germany, and we were asking the German pediatric heart centers, what is your first choice inotrope? And most of them were responding that they were using the adrenaline or epinephrine and milrinone. And when we were asking what is your first combination of inotropes, most of them were responding that they were using adrenaline and the milrinone. But when we were asking what is your first choice vasopressor, so nearly all of them were answering that they were using the noradrenaline. So vasopressin was not taking any action in the therapy of low cardiac output, at least in this survey in Germany. So when is the best idea to use vasopressors in the improvement of hemodynamics? And that these are obvious states where we have a vasodilation, like in the septic shock. In this publication, they were looking at the treatment of septic shock or low cardiac output in septic shock. And as you can see, if we're using a vasoconstrictor 8 hours after stop, you have an increase in urine output and an increase in mean blood pressure, meaning that you